I'm going to try to address the issue of optimizing currently available interventions by talking and trying to draw out some more generic issues in relation to public awareness, clinician attitudes, patient behavior, antimicrobial stewardship, and also a little thought piece on the introduction of diagnostics or near-patient testing. But I want to start with stating again what is probably very obvious to all of you, that the rise of AMR is driven by human action. So it may be a biological evolutionary process, but both its drivers and consequences are socially patterned. And I think I'm going to try in the next few slides to persuade you that the success of any interventions that we have at hand likewise depend on those same determinants. So let's start with the point 1 in WHO's Global Action Plan, which is public education and awareness. And I think it's helpful for us to think a bit about what are we trying to produce awareness about, and also what for. So if you try to answer the question, what is an antibiotic? The notion of there being a generic class of drugs, which are antibiotics, is a complex and difficult thing to get your head around. Even more so resistance, particularly in an environment where people are not necessarily familiar with the notion of a generic class of antibiotics, although they may well be familiar with brand names or specific antimicrobials. And what about understanding of microbes? So I think we need to think in very basic terms about what it is we would be proposing to educate people about, and perhaps even more importantly, what for. The underlying assumption behind public awareness and education campaigns is that we will, by imparting knowledge or understanding, we will change people's behavior. They will use antimicrobials differently. I think we can draw on any number of health education campaigns over the last 40 or 50 years to remind ourselves that trying to impart education and knowledge, giving information, does not necessarily lead to changes in behavior. I would just ask those of you from the UK, for example, if you're aware of the 5 a day that the government campaign has been vociferous on in terms of getting us to eat more fruits and vegetables. How many of us actually either count our fruits and vegetables or eat 5 a day? So it's a very basic point, but it's a really important one. We're trying to think about designing campaigns. And relating to that is the importance of language. I want to use a couple of examples from 2 large projects we're leading from the University of Bristol to illustrate what I'm getting at when I talk about language. The first set of bullet points are based on some work we've been doing in China in village clinics and township health centers to demonstrate that, I don't know if anyone here speaks Mandarin. My pronunciation is awful, so excuse me if you do, but Kangshen Su is the formal term for antibiotics, which is used in all the governmental campaigns. You'll see it on posters in these clinics. Xiaoyan Niao is what everybody describes antibiotics as. It's a term that translates as anti-inflammation medicine, which is a term equally that can be used to describe a whole range of Chinese traditional medicines. They are also described as anti-inflammatory. So it means that linguistically speaking, it's impossible to actually disaggregate an antibiotic from another kind of anti-inflammatory that may not be antibiotic. And as we see in the quote, doctors preferentially use the term anti-inflammation medicine, Zhaoyan Yao, to be able to be understood by their patients, which is an entirely reasonable and appropriate thing to do. So the problem here is that the formal term for antibiotics is neither appropriate nor understood in ordinary language. And I've just put the references to 2 very recent publications, one forthcoming from Marco Hensgen and his team who've been working in Laos and Thailand and have found very, very similar issues in relation to the use of anti-inflammatories to describe antibiotic into special issues that I'm guest editing. I think the good news, however, is referred to on the final bullet point, is that we may harness existing terms and concepts that are available within local cultures to try to couch the sorts of messages we might want to impart about the use of antimicrobials in a more appropriate way. In the 30 years or so I've been working in India, I've lost count of the times when people have described to me that Angrezi dawai tej hai, jordar hai, mein nuksan to karte hain. It's powerful, it's strong, but it is harmful. People are aware that strong pharmaceuticals cause side effects, that ideally you wouldn't use them. Ideally you might use a more Ayurvedic with a small a type of regime of treatment which would allow you to heal the cause, not just the symptoms, but those regimes of treatment take longer. Everybody understands that antibiotics are modern quick fixes. So there's a whole array of cultural precepts already available that we could harness rather than trying to impart some kind of entirely novel messaging around antibiotics. I think it's also important to be concerned about making sure that public education is appropriate to the context. Last year, WHO, CDC in the States, and several other major organizations shifted from the previous messaging, which had focused on completing the course of antibiotics, at last, because of the practical lack of evidence regarding the appropriateness of duration of courses, that everybody knows they're just set by convention rather than evidence. And they switched to, and this is from November's World Antibiotics Awareness Week, always seek the advice of a qualified healthcare professional before taking antibiotics. Now that might seem a very sensible thing to do, but again, just drawing on some as yet unpublished work, we've just finished data collection in rural China. If you just look at the top bar, you will see that almost 90% of doctors in these lower level clinics presumptively prescribed antibiotics for common respiratory tract infections, one of the most common presenting conditions worldwide in primary care. It would be unlikely that all of these are required in terms of the appropriateness of prescribing for the condition. I would speculate, but we haven't done this work yet in India, that you would find an even larger issue of this kind in India, where if you assume that a qualified health professional is only going to prescribe when it is appropriate and necessary, you need to think again. So if I'm saying that what people know and are educated about is not driving antibiotic prescribing, what is driving it? And these are just a couple of slides reporting on some evidence from the UK. And the take-home message really I want to give here is that what drives it is an interaction between the patient and the doctor or the healthcare provider. Most of what people know about the use of drugs derives from their encounters with health professionals, with pharmacies, and so forth. So it is an interactive process, and we need to be careful about assuming that we can target patients alone as though they were autonomous entities. This data and a number of systematic reviews from the UK show that there is often a miscommunication between patients and doctors, whereby, and particularly in primary care, doctors read patients' requests for reinsurance as a sort of request for antibiotics. And so there's a talking at cross purposes going on. And most importantly, the point that I've put in italics, both parties entirely reasonably are trying to minimize risks of harm. For the healthcare professional, the risk is that they do not prescribe an antibiotic when it might actually be needed and life-saving. And the potential reputational, legal, and in some cases in Asia, physical threat that might be consequent on failing to prescribe. It is a rational self-preservation mechanism, if you like. Patients and parents of sick children are likewise wanting to insure themselves against the possibility of walking away without a prescription when it's really needed. And this we need to get to grips with as a genuine problem. And we see in work that's been done in the animal sector, similar interactions between vets and farmers. The other thing, of course, that drives antimicrobial prescribing behaviours is the issue of responsibility, and here's just reports from 2 studies, systematic reviews in Europe across different European countries that showed that most doctors thought that antibiotics resistance was a problem, but they didn't think it was their problem. And I think you find this again internationally. And of course, the issue of financial incentives is likewise a huge driver to antibiotic prescribing in all sorts of ways, ranging from the provision of a script, which can then be filled at the pharmacy down the road, in which there's a kickback mechanism going on between the prescriber and the pharmacist. That's a very common phenomenon in India, particularly as well, for the use of diagnostic labs and testing. I don't think I need to go through any of these bullet points to an audience that very well understands the Indian context, except to just remind you of the last 2 bullet points on this slide, and particularly the final one, in relation to the economic dimension. There is a whole phalanx of rational reasons why people will very often, as a first resort, go to a local medicine shop and buy a few antibiotics over the counter. It's more expensive in terms of time costs as well as actual costs to seek treatment from a health provider, even should there be a high-quality healthcare provider available locally, which is not necessarily the case, of course, in more remote areas. 80% of healthcare costs in India are out of pocket, and this means that the nexus of ensuring access and ensuring appropriate provision of antibiotics is a huge problem. I just want to highlight that in relation particularly to the idea that incorporating near-patient tests will be a solution, because I think we have to recognize that in this thriving medical market, these sorts of diagnostics are going to be introduced, at least in the private sector, where the costs can be passed on to the consumer. Where they can't be passed on to the consumer, that's to say, among poorer sections of the community, they will still be reliant on underfunded public health care or on these small clinics which you find throughout every urban slum in India, where these kinds of diagnostic technologies will not be made available and people will still be reliant on symptom-based or presumptive prescribing. And there is a danger that this will lead to a widening of health inequalities. So I think it's really important in thinking about the introduction of near-patient tests that we make sure that the background research is done on looking at health systems readiness and looking at the kind of feasibility and appropriateness for introducing those kind of tests is done from the start, something that in the case of the Longitude Prize, which I'm privileged to be involved in on the judging panel, we require as a prerequisite for applications. Those tests need to be looked at, how they're going to work in context. Just to point that the H1 prescription, the Lal Lakir campaign have been mentioned already today, and I know I'm out of time, so I won't dwell on it, but just to say, I've yet to see, maybe it's out there, and I'm sure people can correct me in the audience if it's the case, I have yet to see any evidence whatever on implementation. Has anyone been doing evaluations of the success of this campaign? If not, why not? Any kind of interventions that are introduced should be accompanied by a rigorous process of evidence gathering to ascertain how effective they are, and ideally preceded by formative research to understand whether they will be effective. This has already been mentioned by my predecessor speaker, the issue to do with supply pathways, the absence of availability of basic old-fashioned drugs like amoxicillin, which, however, there is good sensitivity to in a number of settings, and importantly, connecting the surveillance not just upwards to glass and national settings, but downwards to avail prescribing guidelines to local people. And I think there's been some skeptical talk yesterday about doctors not using these guidelines. That may be the case in high-tech tertiary hospital settings where physicians believe in their own clinical experience and judgment, but I must say my familiarity with local primary care providers is that they would very much welcome prescribing guidelines and feel the absence of that. So to conclude, these are some of the things that I've tried to address. Thank you very much.